let me just go ahead and go into the questions that were already submitted. And then if you have questions, there again, just raise your hand. No problem. So, one of the first questions, let's get you to the iPad. So, one of the first questions that got submitted was, Coach, what is the difference between angina versus a heart attack? So, let's go ahead and tackle that one. So, angina versus an MI. Now, when it comes to blood flow, and first of all, let me jump ahead for a second. One of the things is this is really important to know. So if you're already in the 14 days program, you're in the cohorts, you've probably seen this already, but this applies to everything we do in medicine. So kind of the starting point for a lot of things is ischemia. So that means the lack of blood flow. And then if you don't have ischemia, eventually there's not going to be enough oxygen flowing in the blood either. So that's going to lead to hypoxia. The next thing in the cascade of events is respiratory distress. So shortness of breath. Notice how I have everything color coded. So ischemia, what's in red, these are primarily perfusion problems. Remember, everything comes down to oxygenation, ventilation, or perfusion. What's in red, these are primarily perfusion problems. Okay, hypoxia and respiratory distress are primarily oxygenation problems where the issue is getting oxygen into the body. And then after respiratory distress, if we don't correct it, that's going to lead to respiratory failure. And then respiratory failure that we don't correct, that's going to lead to respiratory arrest where they quit breathing. And if we don't fix that in time, that's going to ultimately lead to cardiac arrest. So the end point for everything is cardiac arrest. Okay. Now that we know that, let's talk about another really important concept. And this is like the continuation or continuum of how every chronic disease kind of manifests. So we start off with like a lack of blood flow to an area. Well, because now we don't have blood flow to the area, the cells are not getting all the food it needs. So it's one of the first signs of cellular injury is going to be some kind of inflammation. So every chronic disease, think of anything with the word itis on it, with the suffix itis, pancreatitis, carditis, endocarditis, rhabdomyolysis, or lysis. In any of this stuff, there's some kind of inflammatory component. The next thing that happens is the cell gets injured. Now, hopefully we can do something about it before it continues to progress, because if not, what's going to happen is not only is the cell going to get injured, eventually there's going to be so much tissue damage that it infarcts. Okay, so now things are starting to die. Cells are starting to die off, but eventually things are just permanently die, and that's where we have necrosis. Now, so let's tie all that into this concept of angina versus MI. What is the difference? They both are like the same situation, it's just one is worse. So angina is kind of the earlier stage where you have a temporary interruption in blood flow. So blood is not flowing well through a coronary blood vessel. But if you can restore the perfusion, if you can restore the blood flow, the symptoms go away. So angina is where we have an ischemia problem, a lack of blood flow, and temporarily it's going to cause things like chest pain, discomfort, nausea, things like that. But once they sit down and rest, for instance, now they don't have as much demand on their heart and everything is fine. Okay. So now when it comes to angina, we classify it as one of two different flavors. We have what's called stable angina, and then we have unstable. What's the difference? Okay. So let me zoom in here. All right. Notice this blood vessel. So we've got two blood vessels here. In stable angina, this first picture, this is stable angina. It's where you have some plaque that starts forming. Now, how does this plaque form? The number one cause is going to be cholesterol. Now, cholesterol, everybody talks about cholesterol being bad. You have to have cholesterol to live. Every hormone in the whole human body is originally made from cholesterol. If you had zero cholesterol, you would die because you wouldn't be able to make hormones, for instance, epinephrine, norepinephrine, insulin, glucagon. All of those are hormones that you need. Thyroid stimulating hormone, adrenocorticotropic hormone, thyroid releasing hormone, estrogen, progesterone, testosterone, all of those hormones that we need to live, the precursor, the starting point for everything is cholesterol. However, when you have too much cholesterol, or especially too much of the wrong kind of cholesterol, so LDLs, low density lipoproteins, it starts forming this plaque. Now, what happens is when this plaque forms in the blood vessel, initially, so make sure you're paying close attention because Billy, you're going to repeat this back to me in just a moment. So this plaque starts to form, and then it hooks up to the wall of the endothelium, the wall of the blood vessel. But as long as that plaque stays in place, it's nice and stable. Okay? That is what's called stable angina. So you have plaque that forms from like cholesterol, especially the wrong kind of cholesterol, LDL. You have too much of it. It forms a plaque. That plaque stays in place, but it kind of, because it's there, see, like if it, let's do it this way. Let's say there was no plaque there. Now, the blood just flows nice and smoothly. But once you have this plaque there, now there's something kind of interrupting the flow. So this first type of flow, this is called laminar flow. That's nice and smooth, laminar. The next type of flow is what's called turbulent flow. It's where like something's in the way. Kind of think of like water in a stream and there's a pebble or boulder there. It has to kind of go around it. That's the same thing that's happening inside the blood vessel. It's not flowing as easily, but most of the vessel is still open so blood can flow. That's why that's why the problem stops like when they sit down or that kind of thing, or they take a nitro and then the pain goes away in 3 or 5 minutes. That's stable angina. What is unstable angina? Once this plaque ruptures and then moves, the plaque is now unstable. So we now call that unstable angina. Okay, what's the difference? Stable angina is where you have a plaque, it stays in place, but blood is still flowing. Unstable angina is where that plaque ruptures and now it's really getting in the way and blocking the blood flow. Is everybody with me on that? Give me a thumbs up reaction if you're with me. Okay, all right, cool. So that's stable versus unstable angina. So there again, angina is where you have a temporary interruption in blood flow due to ischemia. Now, what is an infarction? An infarction, an MI, a myocardial infarction, it's just where things have gotten worse. So now we have more damage to where there's been blood flow that's been interrupted so long, or so much blood flow has been interrupted that now we went from ischemia to inflammation to injury, and now we're at the point of infarction. Okay? Now, when it comes to this, we have like, okay, so this would be like a blood vessel for ischemia. There's a little plaque there that's blocking the blood flow, but most of the vessel is getting nice blood flow. Okay? On the other hand, let's say in this situation, in fact, let me change the color for a second. Okay, so where I am is right here. In this situation, this is where about 70% of the blood vessel is blocked. In this case, this is the point at which you start having real symptoms. So most of the symptoms happen. So as long as most of the blood vessel is not blocked, they have no symptoms at all. Once you hit the 70% mark, that's when your patient starts having chest pain, or starts having jaw pain, or numbness, or pain in their shoulder, pain in their arm, things like that. The 70% mark is where most of this starts happening. This is where a non-STEMI starts. Okay, so in an NSTEMI, this is where you're going to have ST segment depression instead of ST segment elevation. So this is kind of what it would look like. Okay, so we have, this would be this little area here, right here. This would be the ST depression. Now, what should normal look like? Okay, notice that these two don't look the same. This first one, this is a normal EKG. This second one is ST depression. That happens at about 70, once about 70% of the blood vessel is blocked due to an unstable plaque. On the other hand, let's go ahead and wipe out even more of the blood vessel. Let's make this plaque even bigger to where we have almost no blood flow. So once we hit the 90, or about 95, once we hit about 90 to 95% blockage, this is actually what happens in a STEMI. So now let me actually show you what this looks like. In a non-STEMI, all right, give me a second. Okay, if I were to take the heart and if I were to just cut it in half, like do a cross section of it, and I'm looking down into the heart, these are the 3 layers that I'm going to see. Okay, the outermost layer, type that in the chat. What is the outermost layer of the heart called? So we've got these 3 layers. What are those 3 layers called? What's the outermost layer called? Type it in the chat. Paramedics, you got to know this. Okay, good. Okay, nice. So that outermost layer is the epicardium. What's the middle layer called? The middle layer is very thick. It's the thick muscle part of the heart. That's going to be the myocardium. And what's the innermost layer where the blood is flowing? Okay, that's going to be the endocardium. All right, so let me show you here, let me just copy this for a second. So in a non-STEMI where you have ST depression, let me show you what's happening. Blood is flowing to the outermost layer is getting affected. Oh, I'm sorry. No. Let me say that over. Let me just draw it. This part gets blood. The next part gets blood. But what's happening is the innermost layer, because it's so far away, because the blood vessel is out here, and the innermost layer, because it's so far away from the blood vessel initially, it doesn't get blood flow. So in this case, it's only the innermost layer of the heart that's dying off, and we call that a subendocardial infarct. This is what happens in a non-STEMI where you have ST depression. Let's go back over that. Once there's so much blood flow due to an unstable plaque, once we have at least 70% blockage, that's when symptoms start. In a non-STEMI with ST depression, what's happening is the outer 2 layers are getting blood flow, but the innermost layer is not getting blood flow. That's where the death is occurring, that part of the heart or the heart muscle. We call that a subendocardial infarction. On the other hand, let's talk about when somebody's having a STEMI. So what does it look like? On the EKG, okay, that is a STEMI. This is where we have at least 90. Actually, I want to make this 90 and not 95. This is where we have at least 90% blockage. And in this case, the entire thickness of the heart, all 3 layers die. So because it's all 3 layers, the word for layer is mural, and the word for across is trans. We call this a transmural infarct. It means across all the layers. A transmural infarct. Okay? That is what a STEMI actually is. Now, most people just know the part of, oh, we have ST segment elevation. Now, by the way, why is this segment elevated instead of on the line? Why is that segment elevated? Can somebody tell me that? Who wants to teach that back to me? All right, paramedics, give me a paramedic to answer this one. Why does the line go up? Why do we have elevation? I don't want you to just know that we have it. I need you to understand why we have it. Somebody tell me why.
Is it ventricular repolarization or something like that?
That's a part of it, but that's not really this. Okay, well, keep going. Let's see where you go with this.
No, you scared me. Um, I don't know. I think it's
All right.
because of
So let me help
yeah.
you out. Let me help you out. Just watch what I do for a second. So here's a cell, right? All right. The heart is not getting blood flow, so these cells are starting to die. Remember, they started off with ischemia. That's lack of blood flow. Then we have inflammation. We're going to have injury. We're going to have infarction and then necrosis later. How does all this happen? Okay. So here's your cell. When the cell is at rest, it has a very negative charge on the inside. Okay. Now, during
Correct.
the phase called depolarization, so there's a phase called depolarization, there's a phase called repolarization. During depolarization, here's what happens: sodium from the outside with its positive charge goes in through a sodium channel. Okay, so let's put some sodium in. Boom. Now we got sodium in. And sodium has a positive charge. And so when I take a positive charge from the outside and push it in, what does the charge on the inside become? Positive or negative?
It becomes positive
Okay, so it becomes
because
positive.
potassium comes out.
Okay, hold on.
Right.
Hold on, show off. All right,
Well,
this is good. Let me go to the next one. Then the other thing that happens is we have calcium that goes in through a calcium channel. All right, let's put calcium in with its two positive charges. So now we've got calcium. So we got all this positive charge going into the cell. How did the cell become more positive? Sodium and calcium, both of them have a positive charge. They both go inside the cell. The inside of the cell now becomes more positive. The word for that is called depolarization. But depolarization is not an EKG thing. Depolarization is a cell physiology thing that happens to every cell in the body. Skin cells, heart cells, muscle cells, brain cells, all cells do this. And then what happens is then potassium starts leaking out of leaky potassium channels. Oh, actually, let's do it on this one. So originally, there was potassium on the inside of the cell, but this potassium starts leaking out, and now we get potassium on the outside of the cell. Now, if we get too much potassium leaking out on the outside of the cell, some of that potassium can make its way to the bloodstream, and now we have hyperkalemia. Okay? Now, but what's supposed to happen? How does that sodium, okay, so what happens is the sodium, originally the sodium was on the outside, and originally the calcium was on the outside, but they'd end up on the inside. Well, how do they get out? So what's supposed to happen is there's this thing called the sodium potassium pump, and it pumps the sodium out. In fact, it pumps 3 sodiums out, 3 Na plus, and then it pumps 2 potassiums back in. Okay, now, so that was just background information. Let me get to the part of why do you end up with ST elevation? Have I lost anybody? Is everybody still with me? Give me a thumbs up. Okay. Now, how do you end up with ST elevation? Because once this cell starts to die because of a lack of blood flow, what happens is the pump right here, the sodium potassium pump, it quits working, or it doesn't work as well. Does anybody know what this thing needs for energy? So it's called the sodium potassium ATPase. So what does it need for energy? Somebody tell me. If it's called the sodium potassium ATPase,
ATP.
what does it need for energy? Oh, you got it. Okay. Smart cookie. So it needs ATP. But when you're in a low energy state because you have a lack of blood flow, you're running out of ATP. So let me show you what happens. This is so cool. When you now run out of ATP, the ATPase doesn't work. So what's going to happen is now the sodium that was supposed to get pumped out of the cell, it stays on the inside of the cell. Now, watch what happens. So let me just clean this up a little bit so you can see. So let's say we put Sodium, 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 sodium. We put all this sodium that cannot get out. It's stuck in there because the pump is broken. And the job of the pump is to pump the sodium out so it can go back to where it came from. But now the pump is down. So we've got a backup. So all this sodium gets trapped in the cell. You know what sodium likes more than anything? Its cousin, chloride. So now wherever there's sodium, we're going to now have chloride. And when I put sodium and chloride together, what do you call that? What is it called when it's sodium and chloride? What is that called? Type it in the chat. It's called salt. So table salt is sodium chloride. So now what I just said is sodium got trapped in the cell. It brought in its cousin chlorine. When those two get together, when we have sodium and chlorine together, we now have sodium chloride, also known as salt. And you know what does salt like more than anything? Water. So now water gets into the cell. And if I keep pumping water into the cell, what happens to the size of the cell?
Swells.
It gets bigger.
It gets bigger.
That is called inflammation. That is how inflammation happens in every part of the human body. We just call it different names for different body parts. If it's in the brain, we say increased intracranial pressure. If it starts affecting the optic disc, we call it papilledema. If it's in the pancreas, we call it pancreatitis. If it's in the heart, we call it carditis or myositis. If it's in the GI tract, we call it irritable bowel syndrome or Crohn's disease. But it's inflammation, 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 and this happens all over the human body. So back to the question of why do we have ST elevation in a STEMI? It's because when all this stuff starts happening and all this positive charge gets trapped on the inside of the cell, in the EKG paper, whenever the EKG senses that there's positive energy flowing, everything points up. When there's positive energy flowing on the EKG paper, everything points up. When there's negative energy flowing or no positive energy, everything points down. So in an EKG, when all this positive stuff is trapped on the inside of the cell, that manifests in a positive deflection in the EKG with a positive ST segment or ST segment elevation. Now, I know that was a lot. Who wants to take a stab at seeing if you can repeat this? Garrett, you got it? You want to try it, Garrett?
I can try it.
Yeah, all right, my man. I like it. I like the enthusiasm. Give me a moment to find you.
All right.
Garrett, there he is. Okay, let's put Garrett in. And let's go, my man. Hit me with this. Tell me about, give me the whole thing. Give me stable versus unstable, or give me angina versus MI. Start there.
Angina is the cells become ischemic and then they become hypoxic, which leads to respiratory distress and leads to respiratory failure, respiratory arrest, and then cardiac arrest.
Okay, so let's start with this part. So the cells become ischemic. That's due to a lack of blood flow. Okay, now what is angina versus infarction? Because both of them have to do with this. But
angina, the blood vessels will swell or close up, and then
so it's not that the blood vessel closes up, because if it closes up, we got no blood flow. So angina, or especially stable angina, it's where you have a plaque that stays in place and it's kind of messing with the blood flow, thus causing ischemia. But most of the blood vessel is still getting blood. I mean, blood is flowing through most of the blood vessel, so most of the tissues are okay. That's why you only have pain for like 5 minutes. But then as soon as they rest or they take a nitro, the pain goes away because now we've got more blood flow. That's angina, or that's stable angina. What is unstable angina?
It's where it doesn't.
So what's this situation?
The plaque bursts.
Yeah. So the plaque, you have a ruptured plaque, and now that
Yeah.
clot starts to move. Okay.
Yeah, and then none of the heart gets blood flow,
Okay.
or
So
all
now
three layers of the
that
heart.
plaque is blocking the blood flow. Okay.
Mhm.
So we have an interruption in blood flow. And now instead of just having ischemia, we're going to progress to inflammation. We're going to go to injury, and then we get all the way to infarction. And if we don't do something about it, the next step is necrosis. That's where the cells die. And when enough cells die, you die. Okay.
Yes, sir.
All right. So now let's talk about what is the difference between an NSTEMI, where you have ST depression, and a STEMI, where you have ST elevation. What is the difference in these two situations? First, let's go with
The
NSTEMI.
the NSTEMI is where you'll have 70% of a blockage,
Okay. That's where
and
symptoms
the
start, is when you have at least 70% of blockage in blood flow. So we're only getting 30% of blood flow. Okay. Keep going.
yeah, and the first two layers of the heart are getting blood, but the innermost layer is not, and it's called a
Endocardial.
subendocardial
Okay. Because this
infarct.
innermost layer is the endocardium, and it's beneath that.
Endocardium.
So it's subendocardial.
Okay,
Okay. So a
and
subendocardial
then
infarct. Great. Now tell me about a STEMI.
a STEMI is where no layers of the heart are getting blood, and it's a
Mural.
transmural
Okay.
infarct.
So we have
Sorry.
at least 90% blockage in a coronary artery. We only have like less than 10%. Sometimes it's 100%. But at least 90% of it is blocked. So there's like no blood flow at all. So the entire heart suffers, all three layers of the heart. And the word for that is transmural. Okay. Tell me again, why do we have ST elevation though? Like, why does the line get elevated in a STEMI? What's
When
going
the
on at the cellular level that makes the line go up?
the pump from depolarization to repolarization fails,
Okay. What's the name of
which
that pump, by the
causes
way?
the ATP pump. I can't remember the full
Okay.
name
All right.
of
Let me help
it.
you out, because you just
All
can't
right.
be making up stuff. So it's going to be the sodium potassium ATPase,
Okay.
or also known as
Sodium,
the sodium
potassium,
potassium
ATPase.
pump. What's the
Okay.
job of the sodium potassium ATPase, or the sodium potassium pump? What's the job of it?
To release the positive.
Okay, so it pumps. So ATPase, that's an enzyme. So it's a pump,
Mhm.
and it pumps sodium one way and potassium the other way. Which way does the
Okay.
sodium go?
The sodium goes up,
So it goes out of the cell.
out.
And which way does the
Okay, and
potassium
potassium
go?
comes in.
Potassium goes into the cell. Here, let's put them in. Let's change my colors to match. Potassium goes into the cell. How many sodiums get pumped out? 3. How
3.
many potassiums get pumped in? 2.
3. 2.
2.
Okay.
So it's 3 sodiums out, 2 potassiums in. But what happens when
Okay.
the pump fails? Now the sodium gets
sodium
trapped
gets
where?
trapped
Where?
in the cell.
Sodium gets trapped in the cell. Sodium has a
Mhm.
positive charge. What does sodium attract with it? Because it says, hey, don't leave me in here by myself. Call my cousin. And who's its cousin?
Chloride.
It causes its cousin chlorine. When those two
Chlorine.
hook up together, when sodium and chlorine hook up together, we now have sodium chloride
Sodium chloride or salt. Yeah.
or salt. And who does it attract?
Water.
Salt attracts water. It's real thirsty, because both of these are real thirsty. So they attract water. And as we get more and more water inside the cell, what happens to the size of the cell?
It increases.
The cell size increases. Now, let me show you what happens. So let's say we take a cell. All right, hold on. Follow me here. Let's say we have a cell, and then the cell starts getting bigger. And then eventually it just gets bigger and bigger and bigger. That's called inflammation. But eventually, once it gets so big, it starts getting damaged. Now watch what happens next. Let's damage the cell membrane. Now, for instance, let's say there were some enzymes in here like troponin. But now that we have membrane damage, this troponin starts leaking out. And this troponin leaks out into the blood. So this is why in the bloodstream here, let's put it in or yellow. We have more troponin that starts leaking out into the blood. So this is why one of the things that's going to happen in a STEMI, or it can also happen in a non-STEMI, is we have elevated cardiac enzymes. Where did they come from? These enzymes were originally inside the cell in small numbers, but then they start leaking out, and they all make their way into the blood. So now when we draw a lab value called a troponin, we see troponin inside of the blood. That tells us that the membrane has gotten damaged. Does that make sense?
Yes, sir.
Okay, so this is why one of the hallmarks of a STEMI or non-STEMI is we're looking for elevated troponin. And in just like stable angina, they're probably not going to have elevated troponin. Okay, and so we're going to check a troponin, for instance, at the 2-hour mark. Well, at time 0, we're going to check it about 2 hours. We'll check again at like 4 hours. And if their troponin is like, if both of these numbers, the 2-hour and the 4-hour troponins are elevated, they just bought them a hospital stay. And they definitely need a cath lab too. Okay, does that make sense?
Yes, sir.
How is your understanding of STEMI versus non-STEMI?
Much better now.
Much better now. Okay, the pictures help?
Yeah. Yes, for
Okay,
sure.
cool. All right, so that was the first question. I know that was a long question, but that's why I wanted to start with that one. This is actually a really big topic, and it was the question on angina versus MI. This is a really heavily tested topic to know. Does anybody have any questions on that before I go to the next? Oh, no, I'm sorry. There's more to talk about here. Let me just keep going for a minute. So, angina, STEMI, non-STEMI, is it going to be primarily an oxygenation problem, ventilation problem, or perfusion problem? Everybody type that in the chat. If it's a blood flow situation, okay, that's a perfusion problem. Now, how do we treat it? Well, our main treatment for acute coronary syndrome, whether it's called stable angina, unstable angina, MI, we're going to kind of treat it all the same because we don't have lab values to necessarily tell us. The only thing we have is the patient who's complaining of something, and we have an EKG to look at. So our main treatment is going to be Avon. Some of you may have learned Mona, but Mona, I don't want you to use it because it's definitely the wrong order. But Avon is something you can use because it's actually the order that you would do stuff in, or that you could do stuff in. So the A stands for aspirin. The V is for vital signs. The O is for oxygen if needed. So that's going to be if they're showing signs of respiratory distress or hypoxia. Because going back to what we just said, respiratory distress and hypoxia are oxygenation problems. And so if they have an oxygenation problem, they need oxygen. Okay. If they don't have an oxygenation problem, they probably don't need oxygen. So we don't just automatically give oxygen to everybody having a heart attack or everybody having a stroke. It's only if they need it. The reason we don't automatically give it to them is because high dose oxygen for a long time can actually cause the blood vessels to constrict. So in the heart, it can cause vasoconstriction in the heart. That would make their heart attack worse. In the brain, it can cause cerebral vasoconstriction. That can make their lack of blood flow to the brain. So if they're having a stroke, that can make the stroke worse. Kayla, did you have a question? I see your hand up.
Yes, I did have a question.
Go for it.
It was just in regards to the symptom part when it came to the angina. I was just curious, now would a patient only be feeling symptoms during the unstable angina portion of it?
Primarily. Well, no, I can't say that. They can still have symptoms during stable angina. It's just that in stable angina, what makes it different is that the pain is relieved by rest or nitro quickly. So they sit down, they calm down and rest, or they take a sublingual nitro and then the pain goes away. That was a stable angina. If they sit down and rest or take a nitro and the pain does not go away, it's probably unstable angina.
Gotcha.
Okay.
Okay.
Did that answer your
Thank you.
question?
Yes, it
Okay.
did.
All right. So now let's go back to this part. So the first thing that you're going to do is aspirin, unless it's contraindicated. Then we're going to get vital signs, because one vital sign that we definitely need to know is their blood pressure. Then we're going to give them oxygen if needed, and then we'll give nitro. Okay. Let's talk about aspirin. What does the aspirin do? So when it comes to these meds, we need to know a few things. You don't need to know everything about medications, but you need to know a few things: the indication, the contraindication, the class, and the mechanism of action. Now, in real life, you also need to know the dose. You need to know like the dose and the route. For testing purposes, they're not going to ask you too much about dosages unless it's standard, like just ACLS kind of dosages. But aspirin, what's the indication for it? So the indication for aspirin is going to be acute coronary syndrome or chest pain. Now, all patients having a STEMI don't have chest pain. Like, for instance, you've heard me talk about the triad of elderly. You've heard me talk about the triad of elderly, female, diabetic. Okay? So you got a 60-year-old female diabetic or 65-year-old female diabetic. They often don't feel pain because of the diabetes. It destroys their nerve endings, so they can have like central or peripheral neuropathy. So they have pain, they just don't feel they have pain. So this patient especially may not actually have chest pain, but they may in fact be having a heart attack. Point you want to know: anytime you have this triad, or at least two of the three, so elderly female, female diabetic, elderly male diabetic. Definitely, if you have elderly female and diabetic, you definitely need to take this patient a lot more seriously. So even if they just have, hey, I just don't feel right for no real reason, go ahead and do the 12 lead. So my rule is any complaint above the belly button, do a 12 lead. That means abdominal pain, epigastric pain, just sick for no reason, chest pain, breathing problems, altered mental status, seizure, stroke, any complaint above the belly button, do a 12 lead. I can't tell you the number of STEMIs I've caught, and the patient was just saying, I just don't feel right. And I did a 12 lead. I'm like, oh, I see why you're not feeling right. I need you to be really, really calm. I want you to sit really, really still. I'm going to do all the work for you. Hey, we got a STEMI alert. I need cath lab on arrival. Okay. Now, excuse me. Any complaint above the belly button, go ahead and do your 12 lead. Now, what is the contraindication for aspirin? When would I not give it? So here's what we're going to do. This is what I say. When you come into the house, give them that aspirin. You want to come in and say, bam, take this aspirin. We come in and say, bam, take this aspirin. Why do I say that? Because we're going to say, bam, take this aspirin unless you have bleeding, allergies, or you've taken the max dose. Bam. So bleeding, you have a real allergy to it, or you've already taken the max dose. Okay, you've already taken 324 or 325 milligrams. All right, what is the class of drug for aspirin? What's the class? It has 4 classes. What is the main class? Just type them in the chat. Okay, antiplatelet or antiplatelet aggregator. That's how you want to know it. Antiplatelet means don't make platelets. That's not what it's doing. It makes the platelets still are made. It just prevents the platelets from sticking together. That's called platelet aggregation. So it's antiplatelet aggregation. Okay. What's the next class of aspirin? Okay. Anti-fever. That's called antipyretic. All right. Billy's showing off. It's an anti-inflammatory. No, I love it. It's an anti-inflammatory and, okay, the word for pain, that's going to be analgesia. So it's an analgesic. Okay, so it's used to take care of pain. Now, how does it work? What's the mechanism of action for aspirin? All right, bonus points for who gets this one. Type it in the chat, quick. Come on, guys, I got a lot to cover. All right, what's the mechanism for aspirin? It doesn't stop clots from forming. Remember, it stops platelets from sticking together. That's a different situation. All right, my man Billy, he's on a roll. It irreversibly binds to COX-1 and COX-2. All right, that's cyclooxygenase 1, cyclooxygenase 2. Those are things that happen along what's called the prostaglandin synthesis pathway. For those of you at the pro level, check out the Coach Joshua's 5-star drawing study guide. I literally draw out the whole pathway for you. Okay. And then the dosage is going to be 162 to 324 milligrams. All right. O2. Why do we give oxygen? Because if they have a lack of blood flow, if we have a lack of blood flow and oxygen gets traveled through the blood, that means we're eventually going to have a lack of oxygen called hypoxia. So that's why we're going to give them oxygen. So the indication for that is going to be hypoxia, respiratory distress. Okay? Contraindication. There's no real contraindication to it in an emergency. I don't care about them having a hypoxic drive, if they have COPD, if they're in respiratory distress or hypoxia. Even if they have severe COPD, they still get oxygen. Because if I don't give oxygen, then I'm going to not only have hypoxia, I'm going to have cardiac arrest. Okay, so we never withhold oxygen to somebody in an emergency. We're just mainly concerned about getting, like a COPD patient, getting high flow O2 for a prolonged period, like hours. But in the time that most of you are going to be with the patient, even if you have them on a non-rebreather at 15 liters per minute for the next 30 minutes, they're going to be okay, or they'll be better than dead. Okay, so no relative contraindication for, or I'm going to say no absolute contraindication. All right, the class of oxygen, that's going to be an elemental gas. All right, mechanism, it binds to hemoglobin. Binds to hemoglobin. All right, and the dose depends on the delivery device. Nasal cannula is going to be what? Hey, just unmute for me. Okay, nasal cannula is going to be 1 to 6 liters per minute. Good job, Eric. Now, what if it's a capno-nasal cannula? Okay, it's going to be 1 to 5 liters per minute. What if it's a non-rebreather? Non-rebreather, what you got? Okay, 10 to 15, I just say 12 to 15. And what if it's a nebulizer? Oh, okay. 6 to 8. That's right. 6 to 8 liters per minute. Don't use a nebulizer at 12, 15 liters per minute, because it's like albuterol for them, albuterol for you, albuterol for your partner. It's albuterol for everybody. You get an albuterol. You get an albuterol. Okay. All right. So now what if we're going with CPAP? That just depends on your device. It could go all the way up to 25 liters per minute, depending on what kind of CPAP machine you have and what you hook it up to. If it hooks up to the Christmas tree or if it hooks up to the 50 PSI port on the side of the oxygen tank. It just kind of depends. Okay, now let's go over nitro. Nitro, why do we give nitro in the setting of acute coronary syndrome? What's the indication? There again, it's going to be primarily, it's going to be acute coronary syndrome or chest pain. What's the contraindication for nitro? Okay, so low BP, so hypotension. Okay, what else? Okay, so ED meds, and specifically, I don't want you to call them ED meds. I want you to call them PDE5 inhibitors. Now, they are treated, I mean, the condition is ED, that is correct, but the class is, so the indication of those is for erectile dysfunction, but the class is called phosphodiesterase 5 inhibitor, so PDE5 inhibitor. How do we recognize the PDE5 inhibitors? What's in their name? Nice. Okay, Billy, man, Billy is on a roll. Okay, they end in "fil." So the main ones, the trade names are Viagra, Cialis, and Levitra. Viagra, that's going to be sildenafil. Cialis, that's going to be tadalafil. Levitra, that's going to be vardenafil, but they all end in "fil." So they make the person hopefully feel good. Okay, that's their class. What's the mechanism of action for nitrates? How do nitrates do what they do? So what's the end result of a nitrate? When you give somebody a nitrate, and this is why you cannot give them if they have low blood pressure or if they take a phosphodiesterase 5 inhibitor, okay? Man, we got to give it to Billy tonight. He is on it. So the end result of a nitrate is it's going to cause venodilation. What does that mean? It dilates a vein, okay? Or it can cause vasodilation. What does that mean? It dilates a what? Brendan, I'll come to your question in just a moment. What does a vasodilator dilate? A venodilator dilates a vein. What does a vasodilate? Okay, so that's going to be an arteriole, not an artery. It does dilate arteries, but it's primarily arterioles. Okay, those are smaller than arteries. Okay, now how does it do that though? How does it end up causing venodilation or vasodilation? Eric, you want it? Don't embarrass me now. You want to try it? Oh, come on. I got to put him in. Let's go, Eric. What you got? Hold on. All right. What you got? Can you unmute for me?
I have absolutely no idea. I'm trying to figure it out right now.
Okay. All right. Let me help you out.
Let's
It's no
see.
problem. I got you, my man. Okay.
I
So
was
the
trying to
mechanism of
erase
action of
Billy
nitrates. Here we go. When I give a nitrate, so this nitroglycerin, it gets converted to nitric oxide. Okay. Then the next thing that's going to happen, so it goes this way. Nitroglycerin gets converted to nitric oxide. That's going to
the
activate
GAMP.
something called guanylate cyclase. That's an enzyme. That's going to increase the activity of something called cyclic GMP.
GAMP. Okay.
No, cyclic
GMP.
GMP. So CGMP. And then that is going to cause, so this whole mechanism is what's going to lead to venodilation and vasodilation. Okay, now, why do we care? If I dilate the veins, let's dilate the veins. So here's our person. All right, so hold on. Here's our person. And let's put these veins down in the feet. Okay, let's dilate these big veins in the feet. Let's make them really big. So now that means it's going to hold a whole lot of blood down in the feet. Well, if I put a whole lot of blood down in the feet, that means blood does not come back up to the heart because it's down in the feet. Okay.
Right.
And now if I can't get blood to the heart, what do I call that? So if blood doesn't make it to the right side, it doesn't come here, it doesn't go there, it doesn't make it here, and it doesn't come here. When I don't get blood over here in this left ventricle, what do I call that? That's called a decrease. So the venodilation causes a decrease in preload. Preload is the volume of blood that comes into the heart. And if I don't have blood coming into the heart, blood doesn't come out of the heart. So preload is volume coming into the heart. But if I don't have it coming in, it also doesn't go out. That's called decreased cardiac output. So one complication of nitro is nitro decreases preload, nitro decreases cardiac output. Now, what if I dilate the arterioles? So let's dilate these. Whoa. Let's dilate these. So now when I stretch out these bad boys, the resistance inside this blood vessel, when I make it bigger, do I have more resistance or less resistance if I got a bigger pipe? So like if I have a small
Less
pipe,
resistance.
Say it again.
Less resistance.
I'm going to have less resistance because it's a lot of room. So they're not all like cramped in there. If I make the pipes bigger, I have less resistance. And when I decrease the resistance by dilating the arterioles, I also drop the blood pressure. How does that happen? Well, let's prove it. Well, there's one equation for blood pressure. We know that blood pressure equals heart rate times stroke volume times systemic vascular resistance.
Vascular resistance.
When I decrease the resistance, I decrease the blood pressure. So this is how their blood pressure ends up dropping. Now, why do we not give it to them if they're taking phosphodiesterase 5 inhibitors? Because phosphodiesterase 5 inhibitors also cause this to happen. So if they're taking a medication that drops their blood pressure, and then I give them another medication that drops their blood pressure, I really drop their blood pressure, and now I put them into shock. Does that make sense?
Yeah, that makes sense.
Okay. You seem to have a moment there. You like that?
Yeah, it was moment.
Am I cooking, man, or what?
Yeah, you cooking. Yeah, you cooking. Yeah, you cooking.
All right, so run that back. Give me that back again. Tell me how nitrates work.
All right, nitroglycerin works. It converts to nitric oxide, which converts to
that's called guanylate cyclase.
Okay, guanylate cyclase, which also converts to CGMP.
Yes, cyclic GMP.
Cyclic GMP.
Okay, and then the end result of all that whole mechanism is going to be what two things?
Venodilation and vasodilation.
Okay, let's say if I just dilate the veins, and that's actually the major effect, is dilating the veins even more so than dilating the arterioles. Let's say I dilate the veins, what's going to happen?
You dilate the veins.
Where does all the blood stay?
It goes down to your legs.
Okay, especially if they're sitting. Now, blood due to gravity, all this blood is going to collect in their legs. That means it's less likely to make it back to what?
To the right side of the heart.
Okay, well, to the heart. And if it doesn't make it to the right side, it doesn't make it to the left side. And if it doesn't make it to the left side, I have a decrease in?
It's in preload.
Decrease in preload. And if it doesn't make it in, it also doesn't make it out. So I have a decrease in cardiac. Decrease in cardiac output. Now, if I dilate the arterioles, what happens?
You're decreasing systemic vascular resistance, which also decreases
in the blood vessels all over the body. I have a decrease in systemic vascular resistance. In the blood vessels to the lungs, I have a decrease in pulmonary vascular resistance. So this is why nitrates and PDE5 drugs are also given for problems like pulmonary hypertension. Okay. So once I drop the resistance, whether it's the systemic vascular resistance or the pulmonary vascular resistance, when I drop those resistances, what also happens? I drop the...
You drop the blood pressure.
Okay. And if I give two things that drop the blood pressure, I significantly drop the blood pressure and put them into...
shock.
Check you out, my man.
All right, cool.
Okay. You like that?
Right. Yeah, I like it.
Okay. Now, cool. So let's go to... Any questions so far for anybody? Is everybody understanding so far? Give me a thumbs up or a thumbs down. Okay. What about you, Kayla?
I'm good.
Okay. All right. Cool. All right. Now, let's say we give this patient some aspirin. All right. We're just going to keep going. Let's say we give this patient some aspirin and they take too much of it. Or let's say they already had some, they've been taking aspirin for the last 5 days because they've been in pain. And then you come in and give them some more aspirin because you didn't ask questions like, hey, do you have BAM, bleeding, allergies, max dose? You didn't figure out that they've already taken way more than they should have. What are two major complications of an aspirin overdose? We have an early situation that can happen, and then later we have another situation. When it comes to the acid-base disorders, what are the two primary disorders that happen with an aspirin overdose? What happens in the early stage? Let's go to Brendan. Your camera's not on, but can you hear me, Brendan? Or can you at least unmute? Brendan doesn't want to talk. Let's go to Brian. Okay, Brian, it looks like you're coming on.
Sorry.
So what happens in an early aspirin overdose?
Early aspirin overdose, metabolic alkalosis. Or sorry, respiratory.
Okay. So acidosis. Metabolic alkalosis? No, hold on. That's not right. Say that over.
Respiratory, sorry.
Yeah. Got me saying the wrong stuff. So the first thing that happens is respiratory alkalosis. Right. And if you guys were with me, 2 weeks ago or last week or whenever it was, I did a whole thing on acid base. Go back and watch that because I went a lot more in detail on acid base balance. That would be a great one to know. Okay, so the first thing that happens is respiratory alkalosis, but later, what does it progress to? Brian, you can still go.
Yes. Sorry, my guys are locking in. What was the question?
Respiratory alkalosis is what you get initially, but what do you get later?
It would be metabolic
Metabolic what?
acidosis.
Metabolic acidosis. All right. So now let's keep going with that. In a situation of respiratory alkalosis, how's the pH going to be? Is it going to be low or high? Compared to 7.4, is the pH going to be up or down?
So respiratory opposite. So it would be
Well, first of all, we start with the alkalosis part.
right.
So that determines, so the pH determines alkalosis or acidosis
Right.
first. So is the
So
pH for alkalosis going to be up or down compared to 7.4?
It'll be up.
It's going to be up. Okay. How's the CO2 going to be if it's a respiratory problem?
Respiratory opposite. So it'll be PaCO2 will be down.
Aha. So CO2 is going to be down. And how's the bicarb going to be?
Bicarb should be normal.
Okay. The bicarb may be unchanged. Bicarb may be normal. Okay, good. Now, what about in metabolic acidosis? How's the pH going to be?
So metabolic equal. So acidosis, the pH will be down.
pH goes down, so less than 7.4. How's the CO2 going to be if it's a metabolic situation?
CO2 should be normal, and the HCO3 will be down.
All right, so CO2 should be, it may be normal.
Neutral, I mean.
It could be normal, or it may not be if it's compensating. And what's the bicarb going to be?
Bicarb is going to be below 22.
Bicarb's going to be down. Nice. Okay. So what is our normal pH?
Normal pH will be between, I guess like the sweet spot will be 7.4.
Okay. So 7.4 would be perfect, but what's the normal range?
35 and 45.
You sure?
7.35.
Okay, and that's different. That's different than 35. So it's 7.35 to 7.45 is our normal pH. Okay, what is our normal CO2?
Normal CO2 is 35 and 45.
That's going to be 35 to 45, except let's flip-flop the numbers. Let's put 45 on the left, 35 on the right. Okay?
Right.
And of course, that's measured in millimeters of mercury. And then what is our normal bicarb level?
Bicarb will be 22 and 26.
22 to 26. Good. Okay, nice. See how many things we can tie in with one little situation? All right, so in this, we started off talking about angina versus MI. Okay, we went through the whole thing about STEMI versus non-STEMI. We talked about why your troponin levels go up. It's because the membrane got damaged due to all this cellular swelling. How did the cellular swelling happen? Well, the pump quit working. So the sodium got trapped inside the cell. It attracted chlorine in there with it. Now we got salt in there. And now whenever you got a lot of salt, of course, you got to have a lot of water. So water goes in, the cell continues to swell. The membrane gets damaged. Now stuff starts leaking out. Okay. And when stuff starts leaking out, like troponin, when troponin now goes into the bloodstream, it's now measured in your blood and your enzymes go up. Does that make sense, everybody? Yes or no? Yeah. Okay, cool. Let's keep going. Now, there was another question on, or first of all, let's stop there for a second. Let me take some questions for a minute. Hold on. Let me change my screen so I can see. Does anybody have any questions right this second? Or can we keep going? Keep going? All right, let's go, keep going.